Hello, everyone. We appreciate you all coming out and seeing this presentation. My name is John Mudd. I'm with the Midtown South Community Council, and this event was made possible by our moderators, speakers, partners, supporters, volunteers, People's Forum, and you. Thank you so much for being here for the Greater Good Part 1 of our mini-series. Our Tuesday 6 p.m. forums, the Health Before Profits, which is tonight, and our Rent is Too Damn High, Saving Public Housing, Urbanizing for the People, will explore the causes of rapidly growing inequalities and offer fixes for our crumbling infrastructure. Now, my name is John Mudd, like I said, and I'm the Executive Director of Midtown South, and I've been living here in this area since 1984, and the council's been around just as long. Now, what comes out of my mouth now is don't hold them responsible, okay? The inequalities and disparities are growing, and we exist in a destabilizing conditions because our economic system is callous and inadequate and will not nurture a healthy society. If you were not aware of it before, it should have crystallized during the pandemic. The relationship between the government and private industry is unhealthy for us. It's toxic and detrimental to our survival. We're here to emphasize our basic stabilizing needs, health and housing, and we want you with us for the critical mass to empower us all to demand that our issues be treated as the crisis that it is. We need solidarity because there is not one agency, political party, mayor, governor, president, or nonprofit that will resolve one, much less a confluence of crises. And with that, I'll introduce Robert Hennelly. Now, he runs a radio show on WBAI in the mornings at 7 a.m. Weekdays Weekdays, it's a news, information, analysis, and entertainment, and listeners can call in. Bob Hennelly hosts this, What's Going On, Labor Monday. And if you didn't catch it, we were on there on Monday. He's an award-winning print and broadcast journalist and a staff writer. He was a chief leader for years covering unions since 1897. Bob is a contributor to a lot of other publications for Salon. If you haven't read Salon, it's a great source of news. And he covers economy and politics. And a little bit more about him is besides, oh, by the way, get his book, Stuck Nation. It's for sale. Get it, buy his book, read it. He's got a lot of wisdom. And one thing I can say about Bob, he's got so much passion. He's at this all the time, working hard, digging into the stories. And I'm really feel privileged to know him, as I am with all the panelists, by the way. And with that, I'm going to turn the wand over to Bob.
The power stick, as it were. Thanks so much, you guys, for coming out. To our folks online, we've got dozens and dozens of folks, and we've got hearty souls here. I want to first, of course, I think it's important for us to, I'm just going to say a couple of minutes because there's tremendous expertise. It's like a couple of centuries of people who are, I mean, in terms of life experience and training, that know a lot more about these issues than I do, particularly the details about healthcare. But I just want to try to set the tone a little bit by observing that we have been through a mass death event. The significance of it, I don't think that we have fully processed, and I don't think we will for a long time. And so I know that Reverend Dr. Barber speaks about this often, about our inability to really focus and mourn this significant loss that's happened. And the implication, in my case, it was the loss of my sister Rachel at 60 years of age, a talented puppeteer, ballet dancer, a former member of the circus, who was taken from this earthly plane too early. And that was a consequence of her cancer diagnosis, but also at the end, the fact that the hospital, which had extended her life, and the physicians and oncologists were, I mean, they were pushing the envelope. She had lived like a year and a half beyond her prognosis. And in the final days of her life, a decision was made entirely about staffing and about the financial concerns of the institutions, and she was moved to a congregate care facility right down the street from the hospital. It was on a Friday, and she passed as a consequence of the inability of staffing in that congregate care facility, just a block from the same place where the nurses and doctors had worked so hard to prolong her life. And if we multiply that times all of the experiences of America, we have an obligation to those that passed and to those that suffer with long-term health issues from long COVID to hold the institutions accountable. And that is our hospitals, the for-profit healthcare system. And it's my hope that this is a step in that direction, because right now, as you've probably noticed, the entities that are holding healthcare responsible are labor unions. It's nurses. It's the 7-state strike SEIU had with 85,000 health workers putting something at risk so the world might be better. And within 3 days, talk about collective action making a difference, they were able to change the staffing requirements at Kaiser Permanente and improve the quality of life for all the healthcare people involved. And also, by extension, there are advocates. When they fight for improved healthcare circumstances for us, it's about improving the quality of care. And so there is something exciting happening, that this labor renaissance is a consequence of this great collective tribulation and suffering. It is out of this, and out of the sense of, let us also keep in our thoughts and prayers the 3,600 nurses that Kaiser Health News and Guardian told us perished in the first wave of the pandemic. 700 of those brothers and sisters were from New York and New Jersey. 2/3 of them were people of color. And yet, while we memorialize the consequences of casualties from war, we haven't even begun to start a rudimentary list about these people that put their own self-interest, their very survival, they put that behind the greater good of helping us get through that tribulation. And so it's my hope that this conversation will be about the beginning of holding accountable the institutions, because as it is right now, what we're seeing after this mass death event, when you would think there would be a national robust discussion about the linkage between our for-profit healthcare system, which is based on scarcity, how that let down America, how it extended the period of time of the tribulation, that we have to look at the fact that we're 4% of the world's population and 12% of the COVID deaths. And when we look at how, instead of the nation coming together holistically to fight this disease as a group, what ended up happening is our politicians played the states against each other, the very thing you don't want to have when you're facing a life-altering challenge like COVID. So that's the frame that I'd like to start this conversation in. Dr. Betty Collard is a primary care doctor for people who are using drugs and chairs the Board of Physicians for a national healthcare program, board certified in internal medicine and preventive medicine, focus on advocacy, primary care-based treatment of substance use disorders, and hepatitis C and smoking cessation. She trained in the primary care and social internal medicine residency program at Montefiore Medical Center, Albert Einstein College of Medicine. Dr. Collard is active in physician advocacy and organizing with an emphasis on community leadership and collaboration. Thanks so much for joining us. Lois Uttley, health policy and advocacy consultant and teacher. She's had more than 30 years experience working with advocates and policymakers to protect community access to health care when it is threatened by proposed hospital consolidations. Boy, you're busy. Her professional experience includes more than 20 years of running the Hospital Merger Watch Project and having created the Hospital Equity and Accountability Project, a community catalyst. She's been active in New York State, serving on the steering committee of Healthcare for All New York and facilitating the Community Voices for Health System Accountability Alliance. In 2021, Lois helped win enactment of the state's Health Equity Assessment Act, which will require health facilities seeking state approval for transactions to provide an independent assessment of the likely impact on medically underserved groups of people. In 2022, she transitioned from a staff job into serving as a consultant for nonprofits and community groups. She has also rejoined the faculty in the Masters of Health Advocacy program at Sarah Lawrence College. Not with us now, virtually, is Sharon McLennon Wier, with a Ph.D. executive director. She's been working in the field of rehabilitation counseling and mental health for over 25 years. She received her Ph.D. from Seton Hall University, yay, New Jersey, in counseling psychology in 2012. She obtained a U.S. Law and Methodology certificate from New York University School of Continuing Education in 2003. Her MS degree in rehabilitation counseling at Hunter College, City University of New York in 1998, and her BS degree in biology from Syracuse University in 1993. And then also, do we have Wendell with us? Yes, excellent. Wendell Potter has more than 4 decades of experience as a communications professional. His journalism would take him to Washington, D.C., although he started as a community-based journalist. But he went on to cover Congress, the White House, and the Supreme Court for Scripps Howard newspapers. His first corporate job was at Humana Inc., leading its communications department. From there, he went on to Cigna Corporation, where he worked for 15 years, seeing firsthand how lobbying tilts the scales towards a corporate agenda and against the public interest. He made headlines in 2009 when he testified to Congress about how insurance companies to boost profits, were driving spiraling healthcare costs and the growing number of Americans who were avoiding medical care because of the costs. His New York Times bestseller, Deadly Spin, Insurance Company Insider, speaks out on how corporate PR is killing healthcare and deceiving Americans. Helped to reshape the public debate on this vital subject. Wendell is the president of Business Leaders for Healthcare Transformation and the Center for Health and Democracy. And last but certainly not least, Marianne Pizzitola. Marianne is the president of the New York City Organization of Public Service Retirees, which has been successfully fighting the City of New York and the Municipal Labor Committee's decision to force 250,000 retirees off of their Medicare and into a predatory for-profit Aetna Medicare Advantage plan. Marianne also leads the FDNY EMS Retirees Association, a 9/11 World Trade Center responder. She served as an FDNY EMT from 1991 until 2004. For years, she worked with her union DC 37, Local 2507, to help 9/11 World Trade Center responders navigate the complicated realm of 9/11 World Trade Center Health Program and the Victims' Compensation Fund. She provided essential research that helped the law firm representing NYPD Detective James Zadroga. Zadroga was the original first responder whose death was linked to the occupational exposure of 9/11 World Trade Center toxins in the air that the U.S. EPA lied about, saying it was safe to breathe. Marianne graduated from SUNY at Westbury with a degree in Industrial and Labor Relations. That is our fabulous panel. Thanks so much. So, Lois, you drew the straw. You want to volunteer. Why don't you start? You have the slides.
You know, when we're talking about what's wrong with our health system in the United States, there's a lot we could talk about. Big pharma, big insurance companies, and we have to talk about hospitals and hospital systems. So that's what I'm going to do here. That's sort of my contribution to this conversation, and I'm really eager to hear what the others have to say as well. So I put together a few slides to just sort of give you an overview of what is the impact of hospital consolidation on people, on health equity, especially on people who are medically underserved, who are not getting what they need out of the health system right now, never mind when their hospital is closing. So, I mean, hospital consolidation is really changing the landscape of healthcare for so many of us. We've had more than 25 years now of hospital consolidation that has left way too many communities across New York and across the nation without timely access to needed medical care. Especially urban neighborhoods of color and residents of rural areas have really been suffering as their community hospitals have either closed or joined these big health systems that are proliferating across the country. These acquiring health systems, you know, are often portrayed as white knights saving the community hospital, but the truth is far from that, as I will explain in more depth in a minute. All too often, they make promises to the community that they go ahead and break, and they close services, don't make them better. So we're going to look into this in a little more depth. So, as you can see from this slide, increasing numbers of independent hospitals have been joining health systems. This slide from the American Hospital Association, if you look closely at it, you'll see that about 2/3 of all hospitals in the U.S. are now part of a system. So that era, I was a child in the 1950s. There were then community hospitals that people cared about, felt close to, volunteered at, gave money to, knew the doctors at. That era is gone. It's been disappearing quickly, and this slide shows you the independent community hospital is disappearing. So why do hospitals join a system? Well, for several reasons. At this point, they fear standing alone against the forces of all that's changing in healthcare. They're overwhelmed by the complexities of negotiating what these value-based contracts require, right? It's a very complex thing. You don't just get paid for a service. You have to take a risk that you can provide all the care that your patients need for a fixed dollar amount ahead of time, and it might not work out. And it hasn't worked out, actually, for some hospitals. So that's one of the reasons they're joining a big system to get help with that. They also have aging facilities, and they need access to capital to upgrade those facilities, and they don't have it. Why do systems want to acquire hospitals? That's the more interesting question, I think. Market share. That's the big reason. They want to acquire market share so that they have bigger negotiating power with health insurance companies. You've seen the health insurance companies merging over the years, the hospitals are merging. It's a tug of war where they're both trying to come out on top. There's other reasons too. They want to acquire the physicians and physician practices that are associated with the hospital because those physicians send patients to hospitals. So if you acquire a hospital and all of their physician practices they own, you're going to get their patients too, most of them. And finally, we're seeing, unfortunately, in the case of private equity acquisitions, we're seeing private equity firms buying up hospitals, loading them up with debt, and then sometimes forcing the hospital to pay them to lease the facility that they once owned. It's just a racket, frankly, and not good for healthcare. So let's look at who owns the big hospital systems in the U.S. These are the top 10 health systems in the U.S. It's a list I took from Becker's Hospital Care. And I want to point out a couple things about it. Those that are in red are for-profit. There's a lot of red there, isn't there? And I want to point out that numbers 5 and 7, LifePoint Health and Scion Health, are both owned by a private equity firm called Apollo Global Management. There's not been a good track record of private equity firms helping hospitals. But now look at the blue ones. And this has been the focus of a lot of my work as a women's health and LGBT health advocate. The blue ones are religiously sponsored health systems, most of them Catholic, some of them Seventh-day Adventist, Lutheran, Baptist. When they take over your hospital, they ban all the things that conflict with their religious doctrine. So, look at number 3, Common Spirit Health. That's 140 hospitals that don't allow contraception, sterilization, abortion, infertility services, gender-affirming care. It's a big problem. And most people are really quite unaware of it. So let's talk about now what happens when your hospital decides to maybe join a system. Big promises are made. the community's promise, the merger will stabilize your hospital financially and make sure it's there for you in the future, right? And the quality of care will be improved because you're joining a big system that has excellence, centers of excellence, and all that will enhance the quality.
Economies of scale, they call it, right?
Well, there's that too. And then there's your hospital have access to capital to upgrade the facilities. That's one of the problems that Mount Sinai Beth Israel is facing downtown. I'll talk about that a little more in a bit. So those are the promises. But what happens? Then the promises are broken. Oh, well, we're going to close maternity care because we have maternity care at a few of our other hospitals, and yours is duplicative. So just go to the one 30 minutes from here because it doesn't make sense to have this maternity ward open also. Or we won't be allowing contraception, tubal ligation, or anything that conflicts with our religious doctrine. Or to achieve optimum efficiency and effectiveness, we need to cut the hospital staff by 20%. Or, in the case of Mount Sinai Beth Israel, well, we have to close your hospital entirely. That's the reality of what happens. So now look at how this is affecting New Yorkers. Now, New York hospitals, it's important to say, we don't have any for-profit hospitals. We have all nonprofit and public hospitals. So you would think you'd be better off than other states, right? Because we don't have the profit motive, allegedly, in our hospital system. But what we do have is nonprofit hospitals behaving like for-profit hospitals. We now have, I should say, more than 40 hospitals have closed over the last 25 years across the state, including St. Vincent's downtown, which was just a mainstay of the community. But we now have big hospital systems controlling more than half of the hospitals in the state, 70% of the acute care beds. And I've flagged the 4 big systems here in the New York area who are the big players in that. So let's look at a prime example of what happens when a system acquires a hospital. Beth Israel Medical Center, founded in 1889, to serve Eastern European Jewish immigrants from the Lower East Side, and eventually it expanded to serve all Lower Manhattan residents. So in 1997, Beth Israel joined the Continuum Health System. And then when St. Vincent's closed, all those patients started to go to Beth Israel. 2013 was when things started to go downhill. Continuum, which had Beth Israel in it, decided to merge with Mount Sinai Medical Center to form the Mount Sinai Health System. And within a year, Mount Sinai Health System started closing services at Beth Israel. They closed cardiac surgery. They closed maternity. They closed pediatrics. They closed neonatal care. They closed chemical dependence. They closed physical medicine. One service after another. And guess what happened? You know, the patient census went down. You eliminate the services, you have fewer patients there, right? And they started to lose a lot of money. They were shifting the services to other hospitals within the Mount Sinai system and leaving Beth Israel without those services. So by 2020, they said to the state, hey, we don't need this 700-bed hospital anymore. We can get by with a 70-bed one. And they got state approval to do that. But then COVID hit. All of us were standing there when the state was approving this tiny hospital, saying, well, wait a minute, what if there's a pandemic? This was February 2020. They abandoned the plan to close the hospital, said, oh, we learned we needed to reopen floors to serve people. we're going to keep it open. And then 2023, they decided to close it entirely. And that's what a bunch of us are fighting right now. So I want to just sort of summarize for you who's especially harmed by hospital consolidation. It's people in low-income, urban neighborhoods of color, including immigrants, such as in the Lower East Side, women and other people capable of pregnancy who end up being forced to travel long distances to get labor and delivery care, people with disabilities and frail elderly people who cannot easily navigate a changed health system. That's a big issue with Mount Sinai Beth Israel. LGBTQ plus people, such as myself, who often struggle to find healthcare providers we can trust, and we don't want to lose the ones we've worked so hard to find. And then, of course, people in rural areas. So, what can we do? Okay to move to?
Oh, absolutely. Go ahead.
Okay, what can we do? We have got to strengthen government oversight of hospital consolidation at the state and federal levels especially. New York does have what's called a certificate of need process, which means that hospitals have to apply to the state and prove a need to make a change, to build a new thing, to close something, to downsize, to transfer. And honestly, I would say in the past, that certificate of need process have been captured by industry. It has been dominated by hospitals. Hospitals serve on the board that makes the recommendations. And the whole system is very reactive to what hospitals want to do. It's not proactive. At the federal level, we need to urge the FTC to look at not only would the price of healthcare go up when hospitals merge, but what would happen to the access to care? They really need to take a stronger role here. We need regional health planning. We lost it years ago. We had some. And what regional health planning would do would be assess the need for hospital care in each region and then compare that with what hospitals are submitting as their proposals. Right now, there's nothing to compare it to. There's no plan. There's just whatever Mount Sinai wants to do or whatever Northwell wants to do. And as a result, we have a contrast that I want to put out for you. Here is Beth Israel being closed by Mount Sinai, serving a low-income neighborhood of color, Lower East Side, Chinatown. Lower East Side and Chinatown right now have less than one hospital bed per 1,000 people. The standard statewide and national is 2.4, so they're way below, right? Now, Upper East Side, Lenox Hill Hospital, the Northwell Health System wants to spend more than $1 billion to upgrade that hospital and expand it. And how many hospital beds per 1,000 people are there on the Upper East Side? 10. 10 hospital
So
beds.
there's the health equity and
That's
equality
it.
right there,
there
in the 5 boroughs itself. That was just brilliant. I wanted to just add one anecdote as a beat reporter, because that's all I really have to contribute. But there was a horrible shooting at a federal building on Varick Street, where a gentleman who was retired from the Bureau of Labor Services came back with a gun and shot the officer who was protecting the building. And to this very day, at least when I worked this story for City and State, while they closed St. Vincent's, dear Lord, they left the H for hospital in place in the street. Oh. And in this family man's final moments on this earth, the EMTs took him to St. Vincent's, which is no longer a place that could deal with his wounds. That's one story, but that's the pain in the landscape And this is the witnessing that we have to do. Thank you so much. And again, we'll tie this all in. If Wendell is still with us, I think it would be good after that very compelling discussion about hospitals for Wendell to join in and give his presentation. In the virtual land, in the parallel universe called I'm Not Here, But I Care. Can we call up Wendell? Oh, great. Yeah, St. Vincent's, that was something, I think that was one, and I just wanted to say something also, there he is, about these nonprofits. I call them Fugazi nonprofits, because when you actually drill into the 990, as I did with working with the brothers and sisters with the Steelworkers Local 4-200 with Robert Wood Johnson, that's a nonprofit. It is $5.6 billion and a collection of LLCs and S corporations arranged as a nonprofit, which, by the way, puts a burden on homeowners who are often struggling to hold on to their homes because not only do they make, in the case of Robert Wood Johnson, $16 million for the CEO in the second year of the pandemic, feeling our pain behind the limousine, they also raise the taxes because they're doing the Lord's work and they can't pay property taxes. Wendell, there you are. So, the stage is yours.
Can you hear me now? Oh, excellent. Really good to see you all. I wish I could be there in person. It wasn't the weather that held me back. I was diagnosed yesterday with strep throat, and I didn't want to come up. I wasn't feeling all that great, but I certainly didn't want to make anybody sick. I'm much better today. Antibiotics have helped a great deal. And I'm going to tell you that I am on traditional Medicare with a supplement policy, and I have not paid a hospital bill, a doctor bill, since I got on Medicare. It's just, so I hope that all of you all who are Medicare eligible are able to sign up and stay on traditional Medicare, and hopefully have the ability to get a supplement policy, because it really can save you from a lot of out-of-pocket expenses. As Bob said, I used to work in the health insurance business. I left after a crisis of conscience. I testified before Congress a number of times during the debate on what became the Affordable Care Act, and I have written books. I was a journalist in my first career, as Bob said, and I've returned to journalism. In addition to running those two nonprofits that Bob mentioned, I'm the editor-in-chief of a newsletter called Healthcare Uncovered, and you can find that on the Substack platform. You can go to wendellpotter.substack.com, and you'll see the work that we're doing there. Our objective and our mission is to hold big insurance companies and other players in healthcare accountable. And a lot of the focus of our work is the health insurance business, because it's where I came out of, but not exclusively. That was a great presentation about hospital consolidation, by the way. Thank you for that. And it's something that I also write about. Last year, co-produced a documentary called American Hospitals, Healing a Broken System. It's available on streaming, so I would encourage you to look for that. It is along the same lines. It's about what has happened to American communities that have lost their hospitals or have seen a big downsizing as a consequence of consolidation. I would argue that one of the reasons we've seen so much consolidation among hospitals over the past 20 years is because of the rapid consolidation on the health insurance side. And I was in the industry when that was happening. I managed communications around a number of mergers and acquisitions that Cigna was a part of, and some divestitures too. And by the way, when I first joined Humana was a big hospital company, and it was one of the world's biggest, but it also had a managed care division. While I was there, the company decided to spin off its hospitals to focus on managed care, and a lot of those hospitals now are part of HCA, which is one of the reasons HCA is the biggest. It encompasses a lot of the former Humana hospitals. But the industry consolidated very rapidly, the health insurance business, over the course of 20 or so years, and they were getting the the upper hand in negotiating with hospitals and physician practices in almost every community. So we saw at the beginning of the consolidation on the hospital side, because hospitals felt they needed to do that to have greater strength in being able to and clout in negotiating with big insurance companies. So we've seen on the one hand consolidation among health insurers, hospitals on the other side, and of course the entry of private equity into healthcare. One of the stories that we ran this past week was about the devastation, really, of hospitals in Massachusetts that are part of the Steward Healthcare. They also have some hospitals in Texas. But those hospitals were acquired some years ago by private equity, and the hospitals were saddled with debt, and they're just a shell of themselves now, and they're barely able to keep the doors open. It has become quite a crisis in a lot of cities in Massachusetts. And I know Senator Warren is keenly interested in that. I'm hoping that she and some colleagues of hers can address the growing involvement of private equity in healthcare. I'm not saying it's totally evil. There's a lot of evil in healthcare, but what we have seen a lot of in private equity buying hospitals and some physician practices has led to just the ruination of those hospitals and those practices. We also have a focus on some subject areas like Medicare and Medicare Advantage, and I had the privilege of working with Marianne and John and others in New York last year at an ongoing basis, pushing back against the mayor and the administration up there, trying to herd all municipal retirees into a Medicare Advantage plan. Marianne has just been absolutely valiant, incredibly effective in pushing back and having quite a base of retirees to do that with. And I've just been, it's been a privilege and an honor to work with her. Medicare Advantage has become the dominant way now that people get their, if they are Medicare eligible. More than half of Medicare eligible people are now enrolled in a Medicare Advantage plan. They, for the most part, have no clue what they're getting into when they enroll in these plans. They're sucked in by commercials featuring Joe Namath and many other former stars and celebrities who talk about just how much of how good it would be for people to enroll in Medicare Advantage plans, because you get some discounts on gym memberships and some coverage for vision, dental, and hearing. It's not adequate coverage, but it is something. And sadly, those are benefits that are not part of traditional Medicare. And that's something that my colleagues and I advocate for and work for in Congress, is to try to see if we can put the traditional Medicare program on an even playing field with these private companies that have just really been raiding the Medicare Trust Fund, overcharging taxpayers by the billions of dollars every year, and making money hand over fist. And one of the ways that they do that is denying and delaying care of the people who enroll in these plans. And that's what people don't ever hear about or really know about when they sign up for these plans. Another area that's related, that is a big focus of our work, is prior authorization. And that is a practice within health insurance companies, including Medicare Advantage plans, in which the insurance company, some bureaucrats somewhere, will make a decision to overrule what your doctor says you need, and refuse to pay for your needed treatment or your medication or imaging. And it's become extraordinarily difficult for many people to fight back against this. A lot of people don't know that they have the ability to appeal. So consequently, and it's complicated to appeal. Most of the denials are not challenged, and so people wind up not getting the care that they need. In many cases, going to early graves because they're not getting the care that they need. So that's just kind of an overview of some of the work that we do. We're kind of structured like Consumer Reports and Consumers Union. with consumer reports being the journalism component, like our newsletter, Healthcare Uncovered, and their advocacy groups, the Center for Health and Democracy, and Business Leaders for Healthcare Transformation, are our advocacy arms. And I do quite a bit of lobbying myself. I spend most of my time on educational activities, but I do advocate for policy change and for specific legislation that we feel is pushing our healthcare, or would take our healthcare system in the right direction. Some of you may know that in the past I've been an advocate for Medicare for all. It is what we need certainly is improved Medicare for all, not Medicare Advantage. And I will say that we're in quite some danger as more and more people enroll in these private plans, that the industry certainly will get on board with Medicare for all before too long, but it will be Medicare Advantage for all. And the industry has a lot of friends on both sides of the aisle. So I work with a number of organizations, including PNHP and others, really pushing back on the growth of Medicare Advantage plans, the involvement of industry in our healthcare system, our public programs. And one thing you might not know is that these big companies like United Health and Humana and Elevance, which used to be called Anthem, owns a bunch of Blue Cross plans, Cigna, where I used to work, CVS, which owns Aetna. All these companies now are getting a majority of their health plan revenue, not from the private sector, not from employers, not from individuals, but from the government.
The taxpayer.
Yeah, yeah. Primarily from, yes, our money, but primarily from the federal programs, but also the state programs. Increasingly, these big companies are managing the Medicaid programs in states across the country. So there's a lot that we have to work with and push back against, and to try to advocate for change. And I'd be happy to field questions later on, but I don't want to monopolize the floor here, Bob.
Oh, thank you so much, Wendell. Sharon, Dr. Sharon McLennon Wier, if you would give us can we get the next person on?
I am here.
Excellent, fantastic. We hear
Yes,
your
how
voice.
are you?
And
Good evening,
eventually we'll
everyone.
see-
I am the executive director for the Center for Independence of the Disabled, New York. I'm also a blind person myself. I've been working with people with disabilities over 27 years. And I'm speaking today to talk about the impact of disability and how healthcare is really doing a great disservice to all of us. We would like to say in the disability community is that we are all temporarily able-bodied. At any point in our life, as we age, as something happens to us, we may acquire a disability. And if that happens, we really want to live in a society where the barriers to just enjoying everyday activities, being able to get on a bus, be able to vote, being able to have a job, being able to find clothing that fits you, being able to see a doctor, being able to have the basic tools for your life, you would want it to be there as we talk about universal design. So what we do at CIDNY is that we advocate for inclusion in all aspects. And there are 7 areas of advocacy that we find that people with disabilities have the greatest barrier to. One of them is physical health care. The second is mental health care. The third is housing. The fourth is employment and education. Then transportation and voting. Now, there's no order of importance for any of those aspects. They're all important. And it's important for people to understand that if you do want systemic change and you want to have good health care, have a place to live, have a job that you enjoy, be able to vote, be able to travel from point A to point B, these are just basic human rights that all people are entitled to. But what we see is that the physical health care and the mental health care is one of the factors that are really marginalized and disenfranchising people with disabilities, especially those from neighborhoods where people of color live. If you look at most of the hospital closures within the 5 boroughs, because that's what CIDNY serves as the 5 boroughs, We noticed that a lot of these neighborhoods that are being affected by loss of hospitals or services, especially mental health services, are pretty much in areas where people of color or people with disabilities or seniors are living. This is a extreme advocacy concern to us. And this is why we have united with other disability advocates and other community organizers to really talk about the impact that Beth Israel, as well as the New York I&E Infirmary, if they close, what the impact of that would be on the population. It's important to know that especially the New York I&E Infirmary is the only sensory hospital within New York City that's still left because everything else is closed. What will happen to those that go there for their vision and hearing assessments, people that went there to get evaluated for any throat issues? There's no other hospital that does the great work that this institution over 200 years have done. So we want to bring a highlight to folks that disability is it's not something that is only to those individuals. You know, it's not us against them. It's really about when is your time, and it's important to understand that the advocacy that you do is not about if you're a Democrat or Republican or independent. Disability is one of the things that can happen to anyone at any time. This is why it's important to understand the impact and understand that the one thing that really dictates is economics. Because unfortunately, for some disability types, you may be unable to work the way you used to. And that also lowers your level of options if you don't have the financial resources to get the goods, services, and materials that you need. CIDNY does a lot of great work. It's been around since 1978. It's been part of the deinstitutionalization movement, the independent living movement, where we wanted to get many people out of institutions, nursing home, adult care homes, to live independently in the community. And they did a lot of great work. The disability movement has done a lot of great work to do that. What we found, especially going through the pandemic, is that the ones that were living in institutions were the first ones to go. So it's important to have the services that a person will need, especially if they require home care. Home health aides are essential to sustaining the day-to-day activity, the day-to-day life that allows for a person not to be in a nursing home, allows for the person to live within the community. And even these services are being cut by very greedy people, let's put it that way. We must remember not to put good health care over profits. And we must remember that as the population ages, we all are going to have a disability one day. So let's get it right now and try to adopt universal design and universal access for everyone. Thank you.
Brilliant. Thank you so much. And I think also in the life of an individual, you may have a circumstance where you are disabled and then you come through it and evolve. So we have to look holistically at it. And I'm also think part of this national conversation about the way the pandemic played out, where congregate care facilities were permitted to degrade long before that happened in terms of staffing and the basic requirements. And it seems like, for whatever reason, we don't have the moral character as a nation to take a long, cold stare at what actually happened. And so, thanks so much for that. Marianne Pizzitola, you're up next. I think I wanted to just reframe, because I realized it's been a while since we did the introductions. We've been joined from some more people. Yay. Marianne Pizzitola is a former FDNY EMT who's been leading the charge to prevent and support. She's got around 50,000 folks that are working with her. That's quite a group. That's a good posse to roll with. And what's amazing about this group is that it is so diverse. It represents people that have been giving lunch to New York school children, people that have designed its water systems, people that had answered the fire bell, and people that have been in the police department. It is truly a mosaic of all that's made New York City livable. And so, Marianne, go ahead, explain, how did you get invited to this?
Well, let's see. It started because they went to take away our Medicare. That's how it usually starts. Would you like me to start with
Yeah,
how
go ahead.
what we're doing?
Yes, you got your 7 minutes of fame.
Okay, so great. So the New York City Retirees is an organization that came about in 2021 because at that time, the city of New York went to take away our Medicare, force us into a Medicare Advantage plan. We said, no way, that's not going to happen. We've been paying our Medicare tax for our entire lifetime, and we were promised a choice of healthcare plans. And it seemed that there was a large group of people that did not understand that privatizing Medicare, forcing retirees into Medicare Advantage was a bad thing because they kept saying to us, well, it's enhanced, it has things that, and benefits that are not in Medicare, it's better for you, it's a good thing, you'll like it, you're just confused. No, we weren't confused. We knew exactly what Medicare Advantage was, and as Wendell has taught us for years, it's not Medicare and it's not an advantage. And we say this over and over again, and yet we're not being listened to. And so we have a population that with many of the guests have touched on. We have younger disabled retirees. We have 9/11 responders. Fire, police, EMS are our younger disabled workers, retirees. We have our older retirees who served this city for decades. So we have a bit of a mix of both, and you're absolutely right, Bob. We have a large group of people from all spectrums of civil service in the city of New York, younger and older. And all of us had one thing in common. Well, about 3/4 of us were on traditional Medicare and the city supplement, and all of a sudden all of those choices were being taken away from us, and we were being forced into one Medicare Advantage plan. Or we were told later on, when the mayor went to double down on this, when he had lost in court several times, he took away all of our choices, including the ability even to pay for health care, which of course violated city law, which was one of the issues that we had, and forced us into one plan. He even made this our traditional Medicare senior care supplement so painful to stay in that it prompted that third lawsuit, the second lawsuit. So we are currently right now in court with the City of New York on 3 separate cases. One is in the highest court, the New York State Court of Appeals, and the other 2 are in the First Department Court of Appeals. The New York City Retirees has won at every level so far. We have not lost, knock on wood, that will still stay the same, and we are fighting for traditional Medicare. We have also learned that this is happening around the country. As Wendell said, that more than 50% of retirees are on Medicare Advantage. And I'll tell you for a fact that this is not because they chose Medicare Advantage. Of course, many of them do. But what we're seeing around the country is that these insurance companies and brokers who are making like triple the commissions are approaching municipalities and unions and saying, we've got a plan for you and it's free and it's better than that Medicare that you're already offering them. You put them in this and you'll save money, and that money you could use towards a raise or whatever. And they're doing it because they don't know the difference. And so unfortunately, we're able to stop some of them with this litigation, but others are coming to us after they've been in these plans, like Ithaca, and they have to end up negotiating with getting out of the plans. We've helped other current unions in other states that listened to our message because they were aware of our advocacy, and they were able to go back to the bargaining table and tell their employers, no way, we're not doing this, we're not putting our retirees into Medicare Advantage, and they moved the needle that way. Now we just need to educate the rest of the country not to privatize Medicare for their current collective bargaining or raises, and educate them why. Because this, in our opinion, not only has an effect on what's happening today, but nationwide will impact Medicare trust going forward. That we may not have Medicare, but they surely won't if this trend keeps going.
So, I mean, the other thing I just wanted to circle back to, there was reporting in the New York Times and Kaiser Health Foundation News last year that really blew the lid off of this, which was pretty much a Byzantine world until they did this reporting. what these insurance companies do is they represent to CMS, which is the big cash register in the sky that pays all these claims. They make you out to be in your chart, to be on the deathbed if they can. Ooh, you're really sick. Whoa, it could go either way. We need to get the highest per capita cost for this poor individual. And then when you, the poor individual on your deathbed, but not really, try to access the oncologist, try to access the specialist, welcome to Candyland, where they put you through prior authorizations, and that's how they make their money. Now, unfortunately, as come out, 10,000 people, it's estimated, died as a consequence of this shell game. Tens of billions of dollars have been overpaid, and this just don't believe me or Marianne. This is what the Inspector General of Health and Human Services has pointed out. So I just wanted to make sure to circle back to that because I think that that's important. It is a plan that has been permitted to proliferate, and to some degree, it's all comes back into campaign cash. I mean, we would be naive.
This upcoding is actually happening right now.
Right.
Aetna has been reaching out to transit retirees and New York City retirees that are on the Aetna Medicare Advantage plan, and they're offering them $50 as a healthy home visit to come to their home. And of course, you and I both know that that will become upcoding in the very near future, which will enrich the insurance company. And meanwhile, they're plying people with, "I'll give you $50, and it is a healthy home visit, and I really care about you," kind of a thing. But that's happening today. We got a dozen phone calls on that just in the last 2 days.
Well, and so one of the things that I think was a connection here that happened, and I had the privilege and honor to go with the retirees down to Washington, and I would describe that as a breakthrough moment. Not only did they fill 2 cars of Amtrak, and that's a lot of people, and here they've been fighting, sometimes they're big unions that they love, that they help build their unions. And whether it be DC 37 to the UFT or Teamsters 237, these are the same entities that took the die for $600 million, allegedly. But when these folks came to Washington, while they may have been pariahs here with the MLC, they were greeted as heroes by 400 people. Senator Warren, people from Be a Hero, Artie Barkin's group. And then they found out, as they were escorted through the halls of Congress, that they were the vanguard of a growing national movement that sees health care as a fundamental human right. Did I get it right? Did I miss any details?
You hit that one on the head. Thank you.
So anyway, I thank you so much, and I'm sure we'll revisit these. So you, Dr. Betty Collage, you asked to be last, and so we'll leave the physician with the last word, so to speak.
Thank you so much. I'm sure they won't be the last words, but I wanted to go last because my role in this panel is really to bring a call to action. I want to make sure that everyone in this room, everyone on Zoom knows about an improved Medicare for All plan that we all can advocate for here in New York State. So who is aware of the New York Health Act? Raise your hand. Yes. All right, you're making me happy. So I want to make sure each and every person knows about the New York Health Act, knows that we can be the first state in this country to achieve universal health care, to put all of our taxes together, and not all, just a smaller portion of our taxes together, a smaller portion than what we're currently paying on health care, and that we can cover everyone in this state. But first, I just had to tell a few quick stories because just all of our panelists today each of them brought up at least a few patients who I just saw today, who I just spoke with today, and I needed their voices to be in the room. So first of all, when I arrived today, I was speaking with Robert, and I told him that I have the job that I've dreamt of since I was 3 years old. I've always dreamt of being a doctor for people who are experiencing marginalization. I saw a person experiencing homelessness on the street, and I said, why isn't anyone doing something about this man's ulcers on his legs? I love my job. But I am one of the growing number of primary care doctors who've had to reduce the number of days that I see patients, alongside a number of doctors who are leaving healthcare. I was just over the weekend with a friend who is leaving clinical care because she just can't do it anymore. So I did not see any patients today, but I did, let's see, how does this relate back to everything on the panel? I did provide some care of the phone for a patient who's been hospitalized because She needed a prior authorization for a pain medication that used to be covered, and when she couldn't receive it, instead she ended up hospitalized. I provided free health care over the phone to a patient who can't afford his co-payments because he bought a plan on the exchange that was very expensive. He pays a lot for it every month, but he can't afford the co-payments. I filled out paperwork for a patient who is no longer going to be in network with the hospital that I work for because she has a great job. She has employer-sponsored health care, and that healthcare company has decided that my clinic is no longer in network. I took care of a patient who is most likely going to die of alcohol use disorder and is no longer eligible for inpatient treatment because he has reached the lifetime limit of coverage for that type of care. I also took a call from a patient who was panicking because he was told that his oxygen is going to be taken away because he did not have insurance authorization for it through his Medicare Advantage plan, which when I stayed on the phone for a long time, found out that was inaccurate. They just made a mistake. So, I love being able to have long-term relationships with patients. I love being an advisor to patients when they're going through the hardest moment in their life, and I love being a bulldog and fighting with these insurance companies and with pharmacies and pharmaceutical companies, but as a result, that means that I can only take care of patients 2 days a week because I have to spend the rest of the week doing all of this work. But that also allows me to have time to fight for single-payer health care in New York State. So I want to make sure we all know about the New York Health Act. The New York Health Act is a bill that is currently in the New York State legislature. If it went to a vote today, politics aside, theoretically it would pass because it has majority support in both houses of the New York State legislature. It would cover every New Yorker. So that's everyone who resides in New York State, all residents of New York, regardless of their immigration status, their employment status, marital status, any factor in their life. It would also cover everyone who works in New York State. It would be the most comprehensive health care plan in existence. It would cover primary care, outpatient care, inpatient, specialty services, but then it would also cover vision, dental, hearing services, and it would cover long-term care. So that's home care services, nursing homes for people who need that level of care. It has not yet passed, and so that's going to be my call to action for everyone here to make sure that you're reaching out to your legislators and informing them that if this is something that you support, that this is something that we need to pass. And so the last thing I have to say about the New York Health Act, like I said in the beginning, it is projected by the RAND Corporation, independent think tank, to save money overall. We're paying so much money to receive subpar health care. We know that in the United States we pay about twice as much as peer nations throughout the world to have a lower life expectancy and to have the care that we heard about throughout this panel. So it's projected we would save $40 billion while providing more care for more New Yorkers. So want to make sure you all know about the New York Health Act, the Campaign for New York Health. Look it up, Physicians for a National Health Program. We're having a forum on February 20th, which we'll make sure to share information, but we're really going to make that connection between improved Medicare for all single payer and why we're experiencing these hospital closures that we've been talking about.
Brilliant. You've done this a few times. I want all you have a chance to speak, but I would like to add a little asterisk to this, is that while New York State was closing hospitals, it was also rebating back to Wall Street something called the stock transfer tax. Now, before your eyes glaze over, in 1907, a Republican governor faced with a $5 million deficit, what am I going to do? Introduced 10 cents per $100 on Wall Street transactions. It worked fine. The New York Times predicted that the Wall Street crowd would go to New Jersey. Didn't happen. In the 1980s, after Wall Street put the screws to New York City, remember Ford, New York dropped dead, and unions came forward and put their pensions at risk, Wall Street started getting it rebated back. Rebated back. $400 billion later, it is still occurring. To this very day, when they're talking about scarcity and limited resources, that money is going back to Wall Street during the time of the greatest wealth concentration that we've seen in this country. And we have even some elected Democrats will say, this wealth concentration, if we could only fix it, what is it about? How does that happen? How does all the money end up in one place and we have to have some scarcity and we have to ration care? Well, this is part of that engine. So anyway, that's my little piece I like to bring to it. So we want to hear from you. I've got the microphone. Go ahead. Oh, excellent.
Yes, so we'll be taking questions both on Zoom as well as from the audience. So, yeah, my name is Twee, in case you want to call me, hey, Twee, right? But if you could leave your question to at most 20 seconds, and you're only going to have one question, no follow-up, please, because I'm sure there are questions that we'd like others to share. I saw your hand first, and then yours.
Let us get the microphone to you.
Thank you. My name is Keith. I was writing something in regards to my notes on universal health care. One of the ideas that I have is to establish a medical cadet corps from middle school as well as high school. Like here in New York State, we have specialized high schools when we know somebody wants to go into like a legal field or science or something like that. You know, if the students keep a good GPA in New York State, then they can become a doctor at no cost, no financial cost. The only cost would be their obligation to serve in the medical corps, you know, however many years of education they receive for free. You know, and it's less of a question, but a more of a suggestion in regards to how to keep free health care sustainable.
I would also, one of the things to point out is that we are dealing with, when they say that there's a nursing shortage, and hospitals love this, especially the high-priced CEOs, well, we don't have enough nurses. There are over 1 million nurses credentialed in America who do not want to go to the bedside because of the scarcity model, where they don't have patient ratios so that they can do the work they were called to do. And so I think, Keith, your point's well taken. And one of the things, too, and I guess I want to hear from our panelists about this, in New York City, not very long ago, in living memory, New York City's EMTs were attached to Health and Hospitals Corporation. And today, if you're around, you will run into individuals who are now ER doctors who came through and had a very affordable medical education by working as EMTs. Now we set up a system where if you want to we have this, the level of injustice throughout, like healthcare is like a plantation. EMTs in New York City, just to give you a sense, make tens of thousands of dollars less than firefighters. So a civil service title that is primarily women and people of color that saved lives that were in the front line of the pandemic make tens of thousands of dollars less than firemen that are members of who work on the fire side, who are primarily white males. Today, that's what's going on in New York City. And here's the kicker. You think EMTs would have unlimited sick time. No, they have 13 days. If they're fireside, it's unlimited. So those are some of the things built into this thing. This country doesn't even have a uniform EMS requirement. We so love property in America. You better have a fire department if you have a standing structure, because you won't get your ability to insure your structure. But we do not have a similar requirement for EMS. And in fact, the lowest paid people are the people they call the platinum hour, who are most essential to your care, are the EMTs that you first encounter. That's how little regard this scarcity system has for first responders. Okay, anyone from the panel have any observations? Let's start with the remote folks first to loop them back in. Anybody? Marianne, do you have anything to offer on that?
This is Dr. Wier from
Oh,
Sydney. I just want to make also a comparison of what you just said regarding EMTs. You can get out of a hospital situation. Let's say EMT saves you, you get to the hospital, they do surgery, and you require home care. We know that home care workers get less money than people that work in Dunkin' Donuts or Starbucks. So home care attendants are usually immigrants, women of color, and we can't even pay them $15 an hour, $16 an hour, because the insurance, the home health provider agency is not paying them for the full rate. So it's a double-edged sword. You don't want to end up in a nursing facility or adult care facility. You need the care for yourself, but you can't find the person to help you. And that is a problem as well. Yes, we need nurses, but we also need on both sides of the spectrum. Thank you.
Marianne, any observations on the EMS front? You live that life?
That seems to be a life we all still struggle in. It's 20-something years later. Hopefully that will get better. I know that the current union is still fighting for parity with police and fire and to make sure that their people have the proper protections going forward. It just doesn't seem to ever really improve over the last 20 years, and that's concerning to all of us that live that life.
So anyone else want to offer any? Go ahead.
Yeah, I wanted to comment on how we underuse midwives in our healthcare system. Way uptown in Manhattan and Inwood, the Allen Hospital, which is part of New York Presbyterian, is closing the midwifery service. And this is a group of midwives who are from the community. Most of them are women of color who grew up in Inwood, and they are serving the patients of the community in a wonderful way. For some bizarre reason, New York Presbyterian is closing the midwifery service. The only explanation they've given is something about optimizing perinatal care or something, some vague distraction.
I had them on my radio show. This is such a critical issue, and it also, I think what you were saying before about community-based healthcare, I'm beginning to think like the architecture, we can't just stop at universal care. It needs to be authentically rooted and culturally relevant to the community that it serves. So anybody else? Anybody here in the audience? Oh, go ahead.
Two points. You mentioned New York Eye and Ear in danger. I think we should also include Beth Israel, because it's also in great danger that Mount Sinai is ready to sell off the property for obvious reasons. The other thing I wanted to mention was Senator Gustavo Rivera, who is the key point person in the state legislature. He took over from, as you all know, Richard Gottfried when he retired a year or two ago. And I would be interested to know your comments about how he's functioning in regard to this subject. Thank you.
And also Assembly Member Amy Paulin, who's chair of the Assembly Committee, has picked up the baton. I think that the challenge here is, the one thing I still need clarification on is how will the New York Health Act deal with out-of-state retirees? And I think if we can solve that piece, then you can unite the tremendous organizing drive of the Medicare folks, Marianne's group, with the universal health care push in New York State. That's one issue. The other thing, too, is I think that they need to, as it is now, 1199 is working very hard to try to increase the Medicaid reimbursal. And we have a situation where a lot of the unions are in this world of saying, at an event like this, we're for universal health care. And yet, in Albany, not so much. And so I do think that there's a moment of truth for the American labor movement that has cut some Faustian bargains with Medicare Advantage, where they have actually, AFL-CIO and these unions, many unions have done this, where they've embraced Medicare Advantage. And so, right. And so they need to actually be held accountable for that, because that whole privatization is exactly what set the stage for the mass death event in terms of how many chronically ill people there were in this country. The Cairo Center and Dr. Reverend Barber estimate some 300,000 people died in that cohort of 1.1 million as a consequence of either no health insurance or limited health insurance. It's important to know that generally in America, before the pandemic, 800 people died a day related to poverty. It's the fourth leading cause of death in this country, ahead of homicides. And in 2024, we're talking about the relative perspicacity of Donald Trump and President Biden. We're not having a conversation about the circumstance of the American people. And that's why forums like this are about bending the arc of that conversation to talk about this being the most essential labor right that is on the American scene today. And Liz Schuler and the AFL-CIO need to be held to account on that. While they benefit from this surge of organizing, it's going to ring hollow if they can't deliver on this fundamental thing. What is it good if your members have Cadillac coverage and their poor relatives have nothing?
Is there a reason why
Sorry, let's get to somebody else, and thank you.
Amy Poehlen and Gustavo Rivera, were they invited to this forum?
No, I didn't convene it, so I was brought in.
Going on to our
don't
next
think- I think
question.
you have a lot of forums. This was great to have just regular people.
To the extent that we're holding anyone accountable, we would need some kind of transparency across the industry, which we just don't have in healthcare. There are trillions of dollars in healthcare. Everyone's sicker. Providers are less happy. Everyone's pretty much dissatisfied when we have terrible outcomes. But all of those margin-driven verticals and consolidations will continue because no one on the inside or on the public side has the level of expertise that exists on the side of industry, which is why even the marketing around Medicare Advantage and some of the other things that they're doing is so effective because people just don't know. What are the efforts that you guys can think of that will be most effective in kind of breaking that transparency barrier?
So we'll go to the remote. Wendell, do you have some thoughts on that? Oh, sorry, I caught you during your hydration. So I guess the question is, how can we break through the slick marketing that these hospital combines are so, and insurance companies and big pharma, because we got to throw big pharma. Right.
Yeah, it's a Herculean task. They have so much money to spend. The advertising is very slick, ubiquitous, and they advertise not just to get new business, but to influence lawmakers. A lot of their advertising is done specifically in Washington and state capitals and New York City and places where they need to try to persuade lawmakers and policymakers to see things their way. You're never going to have enough money to overcome that. I think the answer is just to try to get more like-minded people to speak up and take action. Write letters to the editor. Write to your members of Congress, to your state legislator, to the mayor's office, to your city council person. Be active and be a squeaky wheel. And I say that a lot, not just in this in advocacy, but if you are denied something, if you are a victim of abuse at the hands of insurance companies, or if you're getting a bill that's unrealistic and unreasonable and inappropriate, be a squeaky wheel. Fight. And if you're not well enough, hopefully you can find someone who can be an advocate for you. That's a big problem, of course. People, a big reason why so many denials are not appealed is we're talking about sick people, people who are not well, who have a hard time advocating for themselves.
So that was a great. May I ask, are you in the healthcare field? Wow. So I'm just curious. She said she's been in healthcare. So what do you do?
Oh, well, I'm consulting now, but I've been on both the provider and the payer side, all nonprofits, until I found out what nonprofits in healthcare meant. So
The Fugazi part, right?
So now we're going to go to questions online. The first question is from Lizette Colon. Can you kindly ask if NYCHA will cover the thousands of New York City retirees who no longer live in New York?
The New York Health Act. I think we kind of addressed that, but go ahead.
Yes, so as a New York State bill, retirees from public unions would be covered under the New York Health Act, even if they leave the state. But with a state bill, we can't determine the coverage for people who are part of unions outside of the public sector.
Okay, so the next question then is which one here? This one? How do we organize, Lisa Flansreich, how do we organize 70 million baby boomers a la civil rights movement? 70 million of us.
So this is one of my driving passions in life, and this is something that Reverend Barber talks about a lot, which is the 85 million low wealth and low wage voters, roughly a third of the American electorate. And these are people that are qualified to vote, have registered, or haven't engaged, but they could if they took the time. To understand the scale of this, and we never really hear any, why aren't they, I guess there was a Columbia study that said some 46 to 47% voted in 2016. So a majority stayed home in 2016. Now, to give you a sense of what the consequence of that was, and we know from polling and focus groups, they trend to be over 60% for universal health care, labor rights, living wage, reproductive rights. Well, in Michigan, Donald Trump won in 2016 by 10,000 votes. 960,000 low wealth, low wage folks stayed home. There is a potential there for a third Reconstruction and to make health care the top focus of this country. It is in our own hands through the power of agency. And when you ask folks that don't vote who are in this cohort, they say, well, I'm not hearing my issues in the political conversation. So it becomes a conundrum, a kind of drain. The political operatives who are the consultants will say, well, don't spend time on those issues because they don't vote. And then the people that are being marginalized don't hear any kind of conversation about health care, which would include the people that are doing the respiratory care, which would include the home health aides who are fighting to get by and have to take on multiple jobs, or the people here in New York City who have to work and be on call 24 hours without being paid. Indeed, you can go back to the original sin of what happened during, we just had on my program, Senator Brittany Timberlake, who in New Jersey, they finally passed the Domestic Workers' Bill of Rights. In this country, FDR, for all he did that was great, to make a deal to get the Wagner Act and labor protections through for the whole workforce, sold out domestic workers and agricultural workers so that they're not covered by the basic protections that every worker in America, except for gig workers, take for granted. That's how deep this goes. And so I think when you ask how do we organize, we take every opportunity to give people a sense of agency by starting a conversation wherever we are. That includes, like I have to do a cardiac care. They put a garage door opener in my chest about 2 years ago. So I have to go to cardiac rehab and work out with other people who are broken like myself. I go 3 days a week. And I use every opportunity to network with people. Every time a hospital bill comes, and this Hackensack Meridian, they don't give you a single bill with your name on it so you know to be accountable, right? They bill you 17 days a month. So I'm getting a cardiac arrest because I'm getting 10 bills a month. And so I took the opportunity to be the skunk of the garden party. I went into I love my nurses. They take care of me, and they get me through the treadmill and all the things. I've lost 45 pounds, kept it off. It's all because of their work. And I instigate with them. I say, look what the hospital sent me today. And then I send them off. And they do battle for me. And all of a sudden, everybody else is talking the cardiac care facility. There is so many opportunities. Sorry to speak out of turn there, but this is very close to my heart, literally. Anybody else?
So to follow up with that, another question in the Zoom for all the speakers here. Don't we, Leonard Pauletta said, don't we need to fight for campaign finance law controls or more progressive taxation to reduce the power of the corporations and the super rich?
That sounds like a Wendell question.
It is, yeah, and I responded to that in the chat. So glad, Leonard, you brought that up. It's so essential. Whenever I talk to a group, and I'm so glad you prompted me, I talk about money and politics. My second book was called Nation on the Take, How Big Money Corrupts Our Democracy and What We Can Do About It. It is absolutely essential that we spend some time, those of us who advocate for healthcare reform, to get involved in good government groups and fight for campaign finance reform. When I was at Cigna, my team handled the political action giving, the political action, our PAC, and I keep close tabs on what the big companies are doing, where they're giving money. They give to Republicans and Democrats alike, and they give to leadership. Chuck Schumer has been the recipient of quite a lot of industry money, and he was one of the members of the Senate who sadly signed the industry's pro-Medicare Advantage letter a few days ago. He may sign, our letter or the letter that some of us have put together and working with members of Congress, pushing back against the industry and pushing back against their propaganda. But that's the way Washington works, and the way Albany works, and New York City works. We've got to figure out how we can change campaign finance. You all have done quite a bit in New York City, to be honest, with your campaign finance laws that I wish every other place would emulate. But there's a lot more that needs to be done. We really need to curb the influence that these companies have through their political giving and lobbying.
And so the other thing that a piece of that is, and I've watched this with the New York City Council, that of course is the matching funds that exist.
Yeah.
But here's the problem. We do have a situation where the turnout is so anemic in the primaries that it's possible to get elected with 10 or 15%. So again, it comes back to the level of engagement. It is, and it's a challenge because the politics are not accessible and the conversation doesn't relate to our circumstance. So we have to be bold enough to take that conversation back. And you have to connect, for instance, we can't have a conversation about healthcare and talk about a society, as Dr. King pointed out, that spends billions of dollars on war. And there's something built into that is already prioritized. If you're going to spend $900 billion of borrowed money, I mean, let's imagine that we're borrowing this money, so the debt service alone. And so we have to take a whole society approach when it comes to dealing with these issues. And that's why we do see with the campaign finance question is also even holding accountable our friends. And that's also a challenge. And when you have a situation where the Democratic Party does not have a primary for the top office, that leaves a heavy lift here. But there has to be some accountability where even if it's your team and they take hundreds of thousands of dollars from unscrupulous insurance companies, there's a political price to be paid. And that may mean running yourself.
So
Oh, okay.
the next question, and then maybe we'll go back to her. The next question is, from Matthew Weber, if a stroke patient must pay co-pays for each physical therapy, occupational therapy, and speech therapy sessions, does this practice serve to disenfranchise poor, elderly, and infirm individuals?
So I would say that Dr. Wier, I think that's right up your alley, right? Go ahead.
So yes, it does. And what we try to do at CIDNY is try to help that person that has low income try to get Medicaid and other services that can cover some of the copays. Because again, especially after having a stroke, you need those rehabilitative services to help you get better. So you shouldn't be penalized because you can't afford to pay for that treatment. So they can come to us and we can advocate and try to work with them on getting the coverage that they need. The other thing I would just want to say when people are talking about what they can do in the sense of policy, At CIDNY, we teach people how to be community activists. We teach you how to be lobbyists. We teach you about the policies that affect people within your neighborhoods and the policies that can make your life different. So you can join an organization like CIDNY or any other organization that cares about human rights, that cares about disability rights, that cares about what's the impact of the barriers within society that you want to change. And like yesterday, we were in Albany doing lobby day. We took a bus of 30 people and we went around to the legislators, or both Democrat, Republican, and we told them what bills we supported and why they supported and why would it affect them and their family. Because I think when you bring it down to the person's level, that this can happen to you at any point, and that becomes important to them to understand what the overall impact is. So I would say to the guests, don't feel helpless, don't feel powerless. Be educated, get educated, find out about what organizations you can join so that you can learn what the policies are, what those bills are, and you learn how to go and advocate to your local senators. They want to meet with you because remember, your vote is what put them in office. So you can go talk to them. You just need to take the time to do it.
Well, and I would also say that we should remember an Adi Barkan and Be a Hero and the very powerful witness of folks in wheelchairs with varying disabilities in Congress when they attempted to unravel the ACA. In our lifetime, that happened. And it was those folks who had so many other physical challenges that moved the nation. Those images of bringing their circumstance and their authenticity to that place where so much corruption happened was very powerful witness, and we saw that it worked.
Can I also add that one of the effects that I see of patients like our audience member who have to pay these co-payments that are so difficult to afford is that it pits people against each other. One of the actual benefits of doing less primary care is that I've done a little more urgent care recently, so I meet new people every day. One of the people I met a couple weeks ago was coming in to get as much medication as possible because she was about to lose all of her health insurance because through her union, because her wife had been injured, she was in a wheelchair, and they had worked too much in their lives to now afford Medicaid. So we know New York State Medicaid is fantastic health insurance. We know we can do a good job with state-sponsored health insurance in that way. And so now that all she had to say about it was that she was just happy that her wife would still have health insurance, even if she had to retire early, lose her union benefits until she, reaches the appropriate age. And instead of being angry at the insurance company or at the other aspects of the situation that she was in, she was angry at people who are eligible for Medicaid. And so I actually sent her to CIDNY, and I said, you should get involved in CIDNY and advocate for the New York Health Act and for other legislative changes that would benefit you and bring you together with other people who are being harmed by this healthcare system, rather than thinking that people who qualify for Medicaid are the problem.
So this issue of the scarcity imperative is at the core of the evil of the American healthcare for-profit system. In a land of incredible abundance and great wealth that is increasingly concentrated, at the core, the machine and the motor is based on pitting interests against each other and on scarcity. And you see it played out. That's why I want this national 9/11 style commission to look at how it failed so miserably. Because scarcity is what they produce. When it came to N95 masks and you had to, what do they produce? Scarcity. When it came to every other critical thing needed, scarcity. And yet at the same time, we saw wealth concentration take off. And we saw doctors dealing with, and nurses and healthcare professionals dealing with scarcity, and it cost them their lives. And it extended the level of trauma to this nation well beyond what it needed to, had we'd been more in abundance, which we know we have. Anybody else?
Yes, so we have Sarah L. Wilkins, who asked a 20-second question. New York ranks 4th in the nation in the number of individuals aged 60 and over at 4.6 million. By 2030, this population is expected to reach 5.3 million. New York State is working on a Master Plan for Aging, MAP, which is designed to ensure that the older adults and individuals of all ages can live healthy, fulfilling lives while aging with dignity and independence. Has anybody been participating in that effort and know how it will be addressing senior healthcare needs?
So, Marianne, because you're in the middle of, you do so much casework, both in your FDNY MS and helping people navigate the World Trade Center, and then also the horror stories here, you want to address that?
Can you give me the question one more time?
The question is, has anybody been participating in the effort and know how it will be addressing senior healthcare needs?
Right, this was a state effort, and I could tell by the words that were used that it's been kind of come through Albany. It has a kind of official sound to it. It's a program where we commit to keep people living longer. We don't provide them resources, but we hope they live longer. I guess I would like you to assess this question of, is there anything that's going on that you see where they're promoting longevity in New York State?
I'm not necessarily feeling that. I think that I'm fighting this in two places. One, where they're trying to force me into managed care, into inferior Medicare Advantage plans. I don't feel that that's going to keep my longevity. I think the longevity would be for the private insurer who would get the higher profits from CMS, but I don't think for the patient. And then I'm also fighting that on the 9/11 side is because when the World Trade Center program, NIAR CDC, moved their vendor from LHI to Sedgwick, we have almost no providers. And so now I have 9/11 responders who can't get doctors and who have to pay out of pocket to see doctors out of the New York metro area. And I am struggling with this right now, and we've been demanding a hearing on this because there are no doctors available to many of my responders out of state. So that's a scarcity for me because I thought we already fought this, and 20-something years later, if people were really concerned about senior care, they wouldn't be doing this to them. They wouldn't be forcing them into prescription plans that cost them more money. They wouldn't be saddling them with copays after copays. What is copays? Copays are a cost shift to the person to prevent their utilization of medical service. That to me is not doing anything to better my lifestyle, longevity, or quality of care.
Well, and one of the things that I would like to point out also is that what's not widely known is that when 9/11 happened, the EPA told us the air was safe to breathe. And while there's 95,000 first responders signed up with the World Trade Center program, one of the glitches to sell this nationally was that all first responders, as a matter of right, have annual screening guaranteed. Survivors, and that includes individuals who worked for the city of New York, hear me? They could have been at a hospital. They could have been in the civil service making the city work, but if they don't make the proof that they were on the pile, and they can't make their so-called survivors, and they have to exhibit symptoms first before they're picked up by the 9/11 World Trade Center Health Program. That's one of the things that's driving Marianne's group, because there are several thousand of these people that were civil servants and now have very complicated cancer diagnoses, and they've come up with a miracle, an oncologist they have a relationship with, and this threatens to undermine this. We have an in-person question? Oh, there was a gentleman behind you who wanted his first question. Sorry.
One question, please.
Oh, well, I'm a person who follows the news very carefully. And why am I learning at this conference some of the things you're telling me? For instance, I didn't know what a total scam this Medicare Advantage is. I had no idea about it. Where is the journalism on this subject? What's the matter here? And if they're not going to come help us out, do their job, because if I didn't know about it, I would say 90% of the people don't know about it. All right, so how do you get to those 90% of the people? The media is not responding.
Well, I wonder if all the commercials...
One last sentence on that. The media is not responding. Well, if they're not responding, some of you people know how to raise some money. Let's put some ads in the New York Times saying that Medicare Advantage is a scam, very simply. Get it right out there. Use their advertising techniques.
Okay, anybody else? I want to make sure. Are you guys trying to wrap it up now? I'm getting that. Is it the Apollo Theater time? Are you like?
I just wanted to bring up one last thing about value-based care because it's, it's the buzz now and it's not real. It is literally the way it's been implemented so far. It's just going to downstream this from the insurers being those gatekeepers to hospital administrators being those gatekeepers. It lives on the contracts level. It's a metrics chase level. And I'd love to hear from the provider, the clinician, has that yet even trickled down to kind of the practice transformation, or are you still chasing, which most clinicians are, RVUs, and still having these 7-minute,
What does that acronym stand for? If I don't know it, I ask you.
I'll let her take it.
Okay, go ahead.
It's a great acronym, relative value units. So, yeah.
It sounds evil.
Yeah,
It
so
does.
So yes, my work is measured in relative value units.
And you seem so nice.
Not very valuable, though, unfortunately. I'm not doing enough surgery. So yes, the way that value-based care affects day-to-day practice, yeah, a lot of it is superficial paperwork. I imagine it really bloats the administrative level of the hospital because there are new people every day emailing me saying, hey, can you add this diagnosis to your chart? This patient's Yeah, exactly. This patient is in a value-based contract. Can you take another look at the chart and make sure that this and that didn't happen in your visit? They're not telling us to lie or anything like that, but just making sure that, that we're billing the maximum amount. And of course, is that happening at our public hospitals? Do they have the staff to email all the doctors every day and make sure that they're billing at the maximum amount? No. And so that's just one of the many ways that we're systematically underfunding our safety net, the hospitals that are providing care for Black and brown patients. Yeah, so that's my experience with value-based care so far, unfortunately.
We got time for one more. Okay.
Okay, so Christian Sainte-Marie says, when it comes to complex pain patients with multiple conditions, would New York Healthcare Act include integrative approaches like acupuncture?
Okay, so that is a great question. And the New York Health Act is a slim bill, which is a good thing. So, we're trying to get it through first. We're trying to get the funding mechanism through first. And then one of the first things that it would do is to establish a board of New Yorkers from throughout the state, people in rural areas, people in cities, healthcare providers, patients of all different types, in order to determine what are the services provided that aren't currently provided under Medicare and Medicaid, because everything that's currently provided under Medicare and Medicaid, everything that's currently provided by any public union insurance plan would already be covered. But any integrative services that aren't covered by those plans, this board would negotiate whether those would be covered and at what level. So that's something where we would have to, trust our fellow New Yorkers to understand.
Those would be public meetings, though.
That's correct.
Okay.
Yes, there'd be transparency.
So I want to thank you. You want to wrap up? John, thank you so much. Thanks so much for the panel and for the engaging questions, both here and online.
Great job. I'm so privileged to be in the same room with these people, right? It's really wonderful, really. Thanks for everybody being here. By the way, you saw these on your chairs. Those are the bios of our guests here, okay? You can take a picture of your phone and you can look at their bios, you can get their emails. And the idea is okay, what can we do about it? We know the corporations are colluding and we're up against a monster. So what do we do? How do we how do we break those knees and get what we want? That's what we're after. Do you guys want to say one line about maybe where they can come to you and what they can do with you, your program?
That's a good idea to have. Good idea to have follow-up. We should provide. I have my cards with me, but I am. It's R Hennelly HENNELLY 55 at gmail.com. I have a radio program on WBAI that features and talks about all these issues. I'm always looking for great stories and leads, and so go ahead. Any other contacts?
By the way, in that when you take a picture and you get on their bios, it has their emails, and it also has their link And so you can get this information right through that phone of yours.
Okay, at the next venture or the next event, and I'm talking out of turn, we should also pay attention to the people who have their hands raised. That's all. I know we're out of time, but next time, think about that.
We appreciate that.
Thank you.
It's very kind of you to offer. Well, we were going to.
Bob, could you
Sure.
repeat your email?
Sure. R Hennelly, Hennelly 55 @gmail.com.
And Lois Uttley, I'm working across the state and actually the nation with communities that are fighting hospital consolidation, including here in Lower Manhattan, fighting the Beth Israel case. You can reach me at LJ Uttley, that's UTTLEY, @outlook.com.
Again, it's in the bios in that little. We put the link in the Zoom, by the way.
So you can find Physicians for National Health Program New York Metro chapter at pnhpnymetro.org, and you can see our upcoming events on our website, including our February 20th forum on hospital closures.
Marianne.
Yes, you can reach us at nycretirees.org. We are on most social media as NYC Retirees. Right now, we're also working with the state legislature in passing a bill that we drafted that would protect retiree benefits from diminishment. That's the Assembly Bill 7866 with a Senate companion of 8388. And we are also working with Be a Hero and PNHP right now in getting a letter signed, the good Medicare letter that Wendell was referencing before by Senator Warren in getting our U.S. electeds to sign the right Medicare letter. So you can reach out to PNHP or us on our social media. We have reposted that, or as well as Be a Hero, and help us with that campaign. We have 2 links up, one to send an email to your U.S. elected. No matter where you are in the United States, we're asking you to do that. And there's also a link to make a call. You click the link and it automatically dials your U.S. elected official. So please participate. It doesn't matter where you are. It just takes one person to help make a change.
Great. Thank you. Sharon?
Hi, this is Dr. Sharon McLennon Wier. I'm at CIDNY.org, CIDNY.org. Yeah, contact us and we'll help you if you need any services, and we'll also teach you how to lobby and fight for disability rights. Thank you.
Great. Wendell? Thank you, Sharon.
John, thank you. Thank you all, my fellow panelists. Do whatever Marianne says you should do, because she's something else. And John as well, too. You can reach me at Wendell at centerforhealthanddemocracy.org. You can find me on Twitter at Wendell Potter. And please find our newsletter. It's wendellpotter.substack.com. It's free. You can pay a little bit, but you don't need to. And keep track of the work that we're doing. It's a fast-growing newsletter. We've got a lot of folks who are public policy, so it reaches some important folks, hopefully. Thank you very much.
Thanks, Wendell. We want that critical mass, right? We need people, bodies out there when we march. Those marches work, So we need the critical mass. We need the calls. We need to go up there with the groups to Albany when they ask us to come up, write letters. And be a powerful force on the ground here, I think, is very important.
And John, one thing I'd also like to say locally right now, the city council really needs to stand up on this Medicare Advantage issue, particularly because of this population that are the civilian folks that were involved with 9/11 World Trade Center. This is literally life and death for these people. They've managed to survive these 20 years. Because of the clinicians and care they've received. Please, let's not disrupt it.
Yeah, yes. It's right here on the ground is a good fight, okay? Health, housing is the very basic we need to build up from in order to have a decent life here. And so let's get out there and fight. And thanks for being here. Thank you again. And we look to hear from you. We look for your involvement. Have a great night. And make sure you catch our other forums. Okay, we have rent is too high next Tuesday. The following Tuesday is saving public housing, and then we have urbanizing for the public. Thank you again.
Thanks, John.
Thank you
Thanks,
very much.
everybody.
Thank you.